this is the SEQ this thing session. So I'll just be warned because Midushan said that y'all have already done the theory part of it. So without going too much in detail about the theory, I'll just give an overview about the SEQs as to how to write the SEQs. And if y'all want like detailed answers about the SEQs, there is this SEQ already prepared answer sheet is there. No? I think that's what I also went through. That is good enough. But I'll give you an overview. Okay. I hope you can see the screen. පේනවනේ the screen එක පේනවද? හරි. Yeah. So just to tell you some things about the SEQ is main thing what I want to first tell is if no one did this before, I'll just say it again. In terms of this, what they tell you to do, okay, in the if the question says list, state, outline, describe, discuss, those things those are important to see, okay. That will tell you what they're expecting from you, and also at the same time the marks that has been allocated, all of that will kind of give you an idea about how much to write for that specific SEQ. If question එකේදී list කියලා දාලා තියෙනවා නම් don't try to explain a lot in that. Just list 1 2 3 4, put numbers and write. It's always good to do that, and put 1 2 3 4 and write the things that you're more sure of first, because if they ask to list 5 and you write 6, they're going to take the first 5 only as an answer. No, so write the things that you are more sure of and more certain that they will be correct. Write those things as first and list it like that. Now state, I would say state is a little bit more than list. So you can give a little bit more than list. List is if you write two words or something like that, but like I can't say it like that. But if list is just writing it. State is a little bit more than that, where you can write, but again put numbers 1 2 3 4 5, because they write state 5 reasons or something like that. No? Then outline would be something like you try to it's not like describe where you write paragraphs and paragraphs, but outline is just like an overview of the entire thing. So you just give an overview of what. Now when they say outline the management, you don't have to write in describing the management as to why you're giving this drug, why you're giving that, not like that in detail, but you just say, okay, you did this, you do that, you give this, you give this, you give that, like that, just your outline. I'll show you an example of how to write this outline thing. Then describe is where you describe in detail. So you have to give the reasons why you're giving it. If you want, you can give why, if there's certain actions, like if you're giving co-amoxiclav for certain thing, why are you giving co-amoxiclav? What is the coverage of co-amoxiclav? That's why you're giving that. Why are you giving antibiotics for a certain surgery? All that you can write in describe. Now discuss, usually they give discuss when they want your opinion on something, right? It's usually statements like that. I don't know if it's there much in surgery, but when they give you discuss, they want you to write things for it and against it. I think in the medicine SEQ of our year, there was this question about the using what ciprofloxacin in pneumonia, and they were like, discuss whether this decision was correct, whether the physician's decision to start ciprofloxacin for a patient with pneumonia was correct. So there, when you're discussing, you have to give 2 points of view, where you have to say, I disagree with this thing because of these reasons, but the physician could have started this because of that, but my final statement is it is a bad decision because it causes resistance to TB medications, and ciprofloxacin can be used as second line for TB, something like that. So discuss is where you go in and out about everything, and you give a whole comprehensive answer by giving both the positive aspects and the negative aspects. Okay, so that is the thing that I want to first highlight in terms of these things. Then the other one is this management. Okay, I think this was a question that we had in a SEQ paper. The first question in surgery question in SEQ was to I think it said outline the principles of management of acute appendicitis. That was the first question that we got, appendicitis with that abscess or whatever, and then that was like, to outline the management. Now when you're writing in surgery, especially when you're writing management, and if it's an acute condition, don't start with A B C D E. I know in medicine we usually start with A B C D E because they have a breathing system, but in surgery they don't like that, because I remember Sanjeev sir has told before also, don't always write A B C D E when it's not appropriate, because they use it mainly for trauma, so because ABCD is the ATLS protocol starts with that. So don't write ABCD for everything in all the acute conditions. You can not mention ABCD, but you can maybe use the same format when you're writing it, but don't say this ABCD for everything in the acute management for surgery. Like for example, this acute appendicitis. So I'll just show that answer for the acute appendicitis as to what they were expecting, because this was a actually this was a CLD done to our batch itself by Sri Ganesha. So he did this CLD, and I'm pretty sure this was all he was expecting when he came to the answering of that question. So his initial assessment of that patient who came with acute appendicitis, that is, so you identify what is the symptoms in terms of, so he uses this mnemonic called sample, where symptoms, allergies, medications, and past medical history, and the last meal and the events. The same ample history that we take in trauma with the exam with another one with S, because it's an emergency. Then he said check abdomen for signs of peritonitis. Then these are the things he wanted to assess. So you assess the hydration, hemodynamic status, respiratory rate, urine output. So you're going to catheterize the patient, check the temperature, and ABG. So these were the investigations that he was expecting in that answer as well. Because I think the first answer part of that question is what are the investigations. So when it came to the management, when it's outlined, you can actually write it like this. Maybe a little more detailed, not just bed rest, and don't write like this in point form, but write it a little bit in detail. But this is what they were basically expecting. This is your initial management of acute appendicitis. You don't need to write a lot, just this is enough. This is what I also wrote for that first SEQ. So basically just give bed rest, oxygen, always check the flow rate, large bore cannula and fluid resuscitation. You give bloods for investigation, catheterization. So analgesia, any GI condition, it's better to give suppositories, because if the patient is vomiting, if they're coming in pain, acute appendicitis, acute all of these acute conditions in pain, they won't be able to, and they are vomiting because of the pain itself or because of any other GIT problems, they won't be able to take anything orally. So you can always write suppository. Suppository, how much so when you're writing suppository, write what the drug is. So write diclofenac sodium, 50 milligrams, per rectal dose. You can give we don't have 100 milligrams in the board, no, so you can write 100 milligrams. I think Sivaganesa likes it when you say 100 milligrams, but you can say, if you write 100 milligrams, it's you can put a note saying but 100 milligrams per rectal dose is not available in the board, so you give 50 milligrams per rectal dose. You can give up to 3 doses with a maximum dose of 150 milligrams per day. Something like that is enough. Subcutaneous morphine, we know the dose of subcutaneous morphine, we give 5 milligrams, but usually the dose is 0.1 milligram per kilogram. So if you write it like that, then that's more clear about the dose. Then don't give oral for these things, because a patient won't be able to take orally. Then antibiotics, always after blood culture, if the patient is coming with fever and all of this, like in this situation, then you give antiemetics and acid suppression, again if the patient is vomiting. The NG tube not always needed, that depends on the case. And then you have to prepare the patient for surgery or preparing for imaging, whatever the next step of the management is. And then after that, so this is just a pathology, like this thing that has put. Then after the initial management, you have to review again and again, check the trends of the pulse rate and the dropping urine output and all of that. You monitor these initial parameters that you took at the beginning, and then you keep reviewing. So this is all that was, I think, expected for that first question. In terms of initial management in appendicitis. So I think you can use this same format to write certain acute conditions. Now, obviously, there'll be small changes, but I just wanted to give you this overview, because if you use this, it's a very good, I think, SIR's initial assessment and the initial management is just a good overview for you to write the same thing in all these acute conditions, acute pancreatitis, acute cholecystitis. You can use the same. Obviously, the management is different, the ultimate management, but the initial management, you can write the same thing for everything. When you cover all of this, then all of the points are covered. So that is what I wanted to give you this part also, just to cover it in this lecture also, from this CLD, sorry. The other one is, so that was the overview about this SEQs as to how to approach it. Then moving on to the topics for today, I think it was dysphagia, pre-op, and pediatric SEQs. So again, I'm not going to go into the detailed answer of all the SEQs because there are a lot of SEQs. I'll just give you an overview of how to write the SEQs, because I think you have already studied the theory part, and I don't want to take a lot of your time also discussing a lot of SEQs. So when it comes to the pre-op part, this is something that Kanishka sir taught in Genonops, how to write the pre-op part. If they ask you, even for your vivas and the SEQs also, you can use this format. That is basically, so when you to talk about these points, okay, when you have pre-op preparation, these are the basic. You use this as an outline and then for each condition you have to add new things according to that specific condition. So always remember to talk about informed written consent. Then you have to assess the patient's comorbidities. When it comes to assessment of comorbidities, you have to start from the history, examination, investigation. Again, now you have to think of what is the question. If the question has another part saying list the investigations, then don't write that in the question which says to write about how will your preoperative management for this patient be. So read all the questions in the this big question before you start answering a small part of the question. So in this assessment of comorbidities is where you will write the investigations if there is not a separate question asking to you to list the investigations. Then after you have assessed the patient's comorbidities, you have to optimize those comorbidities. That is your management. So depending on the comorbidities, whether it's diabetes mellitus, hypertension, and all of that, you have to write what is your management in this condition. Now in diabetes mellitus, what are the drugs the patient is on, and if the patient is on certain drugs, are you going to stop that drug or are you going to continue the drug? What are you going to do? Now we know that you have already studied this, I think, pre-op part. Metformin, you don't have to, you can take the morning dose because it does not cause intraoperative hypoglycemia. But there are certain differences with different preparations of oral hypoglycemic drugs. And even with insulin, what will you do? All of that you can write it in this third part. How are you going to optimize those comorbidities? If a patient has a respiratory condition, COPD, how are you going to optimize? If a patient has ischemic heart disease, how are you going to optimize? So that will be your third part of that question. So informed written consent, assessment of the comorbidities with the history, examination, investigations, and how are you going to optimize it? So you can write all these things. So you will have studied the individual comorbidities, know how to manage it in the lectures that people have done before this. So you have to just organize that, and according to the scenario given in the question, put that here. Then you have to make referrals. So referrals are, you would do, obviously there'll be an anesthesiology referral, and the other one is if you need, now you have identified these comorbidities and you have tried as an HO, you have tried to optimize the comorbidities, but the whatever the case that is given has very serious problems. The patient has ASA3 or something like that, and the patient has a lot of problems. So then do you need any referrals for the comorbidities? Do you need to make any physician referrals? Do you need to make any cardiology referrals? Do you need to make any endocrinology referrals? All of that also you can write in this part. So anesthesiology referral you will have to do anyways. Then pre-medication is, we know, are you going to give any antiemetics, any anxiolytics? All of that will come under the pre-medication. Then the anesthetist will prescribe those drugs. So you can write those as an HO. You will be giving those drugs now, so you can write those pre-medication part also. Then preparation. So preparation is whether you're going to shave, if there is shaving, it is needed, if there is bowel preparation for certain surgeries, are you going to do bowel preparation for certain surgeries? Those and all you can write under the preparation. So this same thing is the same thing you write for gynecology as well. So this is what Kanishka sir taught. So use the same thing for gynecology and use the same thing for surgery as well when it comes to pre-op this thing. So but make sure you modify this based on the case scenario that is given. Just have this as your framework. Okay. So then moving on to the SEQ, I thought I'll just do this SEQ that came to us, which was a 60-year-old man has obstructive jaundice secondary to carcinoma head of the pancreas. This was the question that we got. So in that it has said list 4 perioperative complications due to obstructive jaundice. Now, so the answers for all these 3 questions also, Sivaganesha did it in his CLD. So I'll just show his slides. Okay, so this is the one. So the first question states list 4 perioperative complications due to obstructive jaundice. So he has listed these 4. So these are the 4. One is hemorrhage, sepsis, acute kidney injury, and acute liver failure. So these are the 4 I think he was expecting. It's hemorrhage, sepsis, acute kidney failure, and acute kidney injury, and acute liver failure. Then that was the first part of that question. And then he has said outline the pathophysiological mechanism. Can you all see when I'm changing the slides like this? Like this thing, you can see the CLD slides neither.
Yes, Abba.
Yeah. Okay. So when it comes to the second one, it says outline the pathophysiological mechanisms of complications listed in 3.1. So this 4th thing, he has given that also. So when you go to the next slide here, it says what is the cause. So he has put that the cause is not sure. absorption is reduced because of the the bile secretion is not there, so you need bile secretion to absorb fat soluble vitamins A, D, E, K. So then AK is not absorbed, so because of that the bleeding risk is high. So bleeding risk is high means you identify with the PTINR during investigation, you will see that the PTINR is prolonged. So then if you can see, the next part of that is outline the preoperative measures that will minimize the complications listed in this thing. So that is also here. So now you have written the pathophysiology of hemorrhage, which is all of that obstructive jaundice causing why vitamin K is deficient and why there is high risk of bleeding. And the prevention is giving vitamin K. Now the how to give vitamin K, that is also you should write those things in detail. So not just write vitamin K, you write I will give IV vitamin K 10 milligrams, and then I will assess the response in only if the INR. So before you give IV vitamin K, you will have to do an INR. Sorry, okay, you have to do the INR. So you do the INR and you will see only if the INR is elevated, you're going to give the IV vitamin K. And when you give the 10 milligrams of IV vitamin K, and then you will wait for 3 days, repeat the PT-INR. And if the INR is prolonged, then you can repeat the dose again. Like that, you write it. So then that's enough. That's enough for that part in terms of hemorrhage. Then the second complication is sepsis. Now again, so the second part is what is the cause of the sepsis? That is again causes not sure exactly, but we know that if there is an obstructive jaundice, there can be ascending infections from the colon into the the bile that is staying that is collected within the bile system, and then that can lead to acute cholangitis and all of that, and also it can lead to a state of sepsis as well, because there's a state of immune suppression that the patient might have. So in that condition, you can explain the pathophysiology of sepsis like that. And then how are you going to assess the sepsis? You would do your normal investigations, doing the full blood count, checking for the white cell count and the differential to see it's a bacterial sepsis that usually you would experience in this condition. So you will have a neutrophilic leukocytosis. You can do the CRP and procalcitonin if you want, and that will show you that there is an inflammatory process going on. So how do you differentiate CRP and procalcitonin? Why is that better? That will tell you that procalcitonin is more specific for infections. So the elevation in procalcitonin would tell you that the inflammation is most likely an infective cause that is causing the elevation. That is why you can do procalcitonin rather than doing only CRP. Because CRP is elevated in infective causes and non-infective inflammatory causes as well. So the third part of the question is, how are you going to prevent this, or how are you going to manage that condition? It's your antibiotic prophylaxis. When you're writing antibiotic prophylaxis, it's always good for you to write the name of the antibiotic and write the dose of the antibiotic, the route you're going to give to. And if you remember the frequency, you can write the frequency also. But because those will also carry marks, because it will show that the examiner that how to give these antibiotics, and that you have seen them giving these antibiotics in the ward, and that you know what to do when you get a patient like this. So in terms of sepsis, in terms of cholangitis, if you talk about cholangitis, we know you give piperacillin tazobactam. Now the dose, I don't remember the dose, but if you remember the dose, you can write it, or you can say I'm going to give IV coamoxiclav 1.2 grams, and then you can at that point you can say why you're giving it, what is the coverage. So we know that IV coamoxiclav is a broad spectrum antibiotic, so we give broad spectrum antibiotics to cover for this. And whether you want to give anaerobic cover or not is something that you can discuss in your SEQ as well. So remember that SEQ doesn't carry negative marks, but don't write the wrong thing. But if you're not sure, you can write it in a way that you're trying to discuss and say that this can also be given because of this reason, because you're entering into the abdomen cavity. I would also like to give some certain anaerobic cover, something like that. If you write it like that, it's okay. But if you're not sure, maybe better to not write it as well. Okay, so that is a part with sepsis. Then we have AKI. Now AKI, there are different theories as to why AKI is caused in obstructive jaundice. That is, there is an issue with this hepatorenal syndrome that occurs with cirrhosis. There is a component that may occur with hepatorenal syndrome with obstructive jaundice as well. I think Ashanaya's book has that theory part as to exactly how it occurs. I can't remember the exact pathophysiology, but read that part, which is something that you can write. Another thing you can write about AKI is also that the patients are usually, they have loss of appetite with obstructive jaundice, so they have reduced intake orally. So then if they have reduced intake, they can be dehydrated, and dehydration can itself lead to AKI as well. So that is another thing that also you can write. So when it comes to AKI, what I'm going to do perioperatively to prevent AKI is it's mainly hydration. So you're going to give IV fluids, you're going to give oral fluids, and then you have if the patient is infected and the patient is having sepsis, you treat the sepsis and you monitor the UOP. So you have to, if you want to monitor UOP, you can say depending on how the condition of the patient is, you can catheterize the patient and you can monitor the UOP, or you can just monitor the UOP as well if the patient is stable. So that is in terms of prevention of AKI in the perioperative period. Okay, so this is as in the treatment. We give dialysis and hemofiltration. Only there are certain indications to give this. Just this thing to remember the indications. You can remember the mnemonic AEIOU. That is in medicine. Basically, but you when you give dialysis for AKI, so A is acidosis. Uh, uh, E is electrolyte imbalances. If there is excessive medically resistant hyperkalemia here. Hello, my connection is unstable. Am I heard still? Is it clear? My line, is it clear?
Okay, bro.
And okay, sorry. Yeah. So that is with AKI. So AKI is your how AKI occurs and how to treat perioperative AKI and how to prevent the patient going into AKI during surgery. Then the other complication that they were expecting was acute hepatic failure. So this can occur because we know obstructive jaundice can lead to liver failure because of the buildup of bile within the liver, and that can cause acute liver failure as well. And the patient can then go into further complications, which is hepatic encephalopathy. The bleeding, what you saw earlier, can be exacerbated. Hypoglycemia because the glycogen stores are affected, and the patient can go into fluid electrolyte imbalances as well. So how are you going to manage this? You do the liver functions and you monitor the liver functions, and mainly managing of liver failure is conservative management. So you can't manage all of this in detail, and you have already discussed this management before itself. So mainly is conservative management. So I think that is all that was expected. I think this is not. Yeah, this is something that else that he has put as cardiovascular instability, but this can occur with other surgeries as well, neither. So the main things that he was expecting were probably those four, and uh, yeah, those four, and that is what is the main management in the terms of the perioperative management of this patient. Okay, then I have given this other thing about regarding the perioperative assessment of blood loss and transfusion. So this question states, describe preoperative measures to minimize blood transfusion during surgery. So this I have listed this out. I'm going to go a bit fast because I think it's time is also going. So I'll send you these things where as to what, because this is mainly just studying this in terms of how to assess bleeding before surgery and how to minimize blood transfusion and how to intraoperatively how are you going to assess the bleeding as well. So there are theory stuff to study. So I'll send this to you all because I'm not going to go into detail in all of this because it'll take time. So just want to give you an overview of this preoperative assessment. Mm, so the same thing is here, okay? In this condition, like I said before, now here they have asked you in this condition, they have given the SEQ and they have given that the patient has COPD. And then they have asked specifically, how are you going to improve the respiratory functions prior to the surgery? So like I said earlier, now in this format that you have, they're asking only one thing here. They're asking only to optimize the comorbidities. They're asking how are you going to improve the respiratory functions. So then if there's a smoker, you COPD, no, you'd ask him to stop smoking first. Then you can give the incentive spirometer, you can give. Another thing is they like the word prehabilitation. Okay, so use those words while writing your SEQs, because even in the long cases when you're saying they have this booklet, no, in the ward there's a booklet with prehabilitation. So you tell, I will give the booklet with prehabilitation to the patient and educate the patient about, then they will ask you what is prehabilitation. So you can say all of those things because you have seen that being done in the ward. So write that also in your SEQs that you will prehabilitate the patient prior to the surgery. So these are some other things that are there. You know, you can do physiotherapy for just physiotherapy sessions. You give incentive spirometer and you educate the patient on how to use the incentive spirometer. Then you can do lung function tests and check whether the patient's lung functions are adequate, and then based on that you can give certain inhalers to for the patient to use, because he's COPD. You know that what are the, depending on his grade of COPD, you can give inhalers. Then you can do steam inhalations, then exercises to improve his muscle function, uh, and reducing the weight. So all of these are probable things that you can do to improve his respiratory functions. Okay, so then the same thing is asking again here, how to prepare him for surgery. But in this condition, remember, he is hypertensive and he also has type 2 diabetes. So you have to try, and they have given here medications as well. So you need, based on your theory of how to of preoperative management, you need to write about all of these drugs, whether all of these drugs can be taken the day before the surgery, or what are the changes you're going to make for these drugs. Okay. And you can say you want to check his blood pressure as well and see if it is normal or not. We know that in blood pressure, if it is, if the patient is on treatment and the blood pressure is high, then you can take the patient, ask the patient to take the treatment, and you can do the surgery on that time itself. But if it's a new onset hypertension, then you have to postpone the surgery. Okay, like those theory stuff also just go through. Then the other thing that I wanted to do today first, is there anything that you want to ask from this? Um, oh, okay. So the next part is that I want to do was this pediatric surgery part. So pediatric surgery also, so actually the pediatric surgery SEQs are not difficult because they are mainly theory. Okay, so I will here in this one I'll just tell you, I'll give you sources and give you what to study, because I have some notes on pediatric surgery which I got from, I think Nimesh got it from someone and sent it to me, and those are very good notes actually. So I'll just send those notes to you and you can read that, and that is actually give you that is enough to answer all of these questions that are there in pediatric surgery. So I have compiled all the SCQs in pediatric surgery and put it here, which also I can share with you all. So the main topics to study in pediatric surgery would be intussusception, undescended testis, acute scrotum, posterior urethral valve, then congenital hyperpyloric stenosis, hydrocele, and hernia. Mainly umbilical hernia is what they ask. So just cover these topics is other main topics that they ask in SCQs. And so I'll just show you something that they have asked. Hmm. Something to say about acute. Yeah. So here, most of these things are write notes on, list 3 types of groin hernia. Those are the questions that they will ask. So if you say acute scrotum in a 12-year-old, so I'll show you the note that I have. Mm. Okay, so this is the acute scrotum in children. So if you can see, you don't need to go into detail. When they have acute scrotum in children, you have to have 3 differential diagnoses, and you have to write it in the order. Okay, now if you're having acute scrotum in children, first diagnosis is testicular torsion. That is always your first diagnosis that you have to rule out. So after your testicular torsion, your second diagnosis would be the torsion of the testicular appendage. That is your second differential diagnosis. And thirdly, just a little bit about the pathogenesis, then etiology. Again, very little about this. This has some excessive things. You don't need to write a lot. You can just write etiology is mostly unknown. That is enough. Then epidemiology, if you can remember, or else no need. And diagnosis is the main part now. So how are you going to diagnose? And what is the presentation? So in history, what is the presentation? And what is the examination? What is the presentation? Now, because these are the questions that they will ask mainly, is how are you going to differentiate your differential diagnosis? So your differential diagnosis is testicular torsion and torsion of the testicular appendage. So how are you going to differentiate that will be in your history and examination. So we know in testicular torsion is acute onset, unilateral scrotal pain will be there and it's severe in nature, and there will be autonomic symptoms like vomiting associated with it because of the pain. And examination, you will have tender testis, erythema swelling of the hemiscrotum, high lying testis compared to the opposite side, then any movement will exacerbate the pain, and cremasteric reflex may be absent. Now these things you can write in the SEQ, but sometimes when you say it, some people don't like it, but in the SEQ you can write it. Okay. Then this ultrasound scan is not done usually, and you don't exclude based on ultrasound scan. We know that for testicular torsion you have to do exploration, and that's exploration. Surgical exploration is the only way that you can exclude the diagnosis. So then after you write the diagnosis in history and examination, then we know that there is no investigation to confirm. You go to management. So management again, now this is too much. Okay, don't try to study all of this. Just write what I'm going to do. Exploration within 6 hours, and you can just write its fixation, right? So archidopexy, that's enough. No need to write in detail, and they're not expecting you to know all of these things as well. So don't study all of this. And then if you want, you can write post operatively what are the complications that the patient will have. That's enough. Okay, that's all you will expect for short notes. And then if they some questions, I saw there's another question about they've given a case scenario about what patient come with acute scrotum, and then they've asked you to differentiate testicular torsion from torsion of the testicular appendage. So again there he will say that the tenderness is confined to one area. Okay, so then and there is this sign called blue p sign, where you will see a small change, a blue color spot in the scrotum, which may be seen. It's not very obvious, but that is one of the things signs that you will see it in the testicular appendage, because we know it's only one part of the testis, just that appendage of that part that is getting torsioned. So here the management is you can just give analgesics and treat the management. There is no surgical management as such. Okay, unless you want to exclude testicular torsion, you don't do an opening in this point unless you're very sure that it's a testicular appendage. So that is what they'll expect here. So this note is actually very nice, and I'll send it to you so you all can study this. So this note, the similar notes are there for all of the pediatric. Wait, I'll try to get that. So for all of the topics, the main topics that I said, these notes are there. Okay, so you have to understand the test is what to do is there. So all of these things are there. I have also written the classes that we got in each of these things that is there. Then there's another question on non-retractile penis. That also I have a note which I will send for that as well. Then other SEQs that you can get pyloric stenosis. What I can do for pyloric stenosis. Again here, I just don't go through everything in detail. Just look at stenosis. There is a CLD that was done by Naveen sir and Anoja madam. That is also good. I think that is better than this note. If I have that CLD note, I will send that as well. Other than that, that is what I wanted to say. I didn't want to go into detail about each of the SEQs as to how to answer it. Is that okay? Or is there anything else that you want to do? I didn't want to take a lot of time. Is that okay? Do you want to do any more SEQs like in detail? Yes, no.
Naveen,
Uh, yeah.
usually, rather than this long case,
Mm-hmm.
they'll ask in SEQ only this pediatric surgery and like emergencies. Okay.
Yeah. Oh, only pediatric surgery. Additionally, you have to
Apart from
study.
our surgery long cases,
Yeah, yeah. Additionally, you have to only study the
yeah,
pediatric
only pediatric surgery.
and orthopedics also. Orthopedics also, there's a question no, usually. And
Okay.
trauma also you have to
Okay.
study. Trauma, orthopedics, and pediatric surgery. I think those three are the ones that are not there in the long cases.
Okay. Okay. Okay.
Yeah.
Huh.
See. So anything else you want to do with SCQs? Because I think SCQs are taking a lot of time also discussing SCQs. I was wondering to just do it quickly, just to give an overview of the SCQs. Is there anything, do you want me to do a session where to discuss all the answers in detail like that? I think that will be a waste of time for you all also. That's what, if you want, you can let me know. I can do it. Or else, is there anything else that you want to ask? No. What are the other resources that y'all want? I can send those speed things. Anything else that y'all need? Any resources that y'all need? PDFs, notes. Nothing. So this is okay. Orthopedics.
But if you
Orthopedics.
have that orthopedics and trauma, like SEQ notes or
Yeah,
something like
orthopedics.
pediatric surgery, please send that.
Okay. I'll send the trauma. I don't have one, but orthopedics I saw one in the drive and I used that only to study. I'll send that.
Okay, okay,
Okay. Okay. I'll send that. And I'll send the PED ones also. All the PED notes I'll send it. Okay, no? Shape neither.
okay, okay. Yeah,
Okay.
thank
Okay
you.
then. See y'all guys. Okay. Bye. Bye.
Okay.